Well, welcome to Pain Week 2011. It's nice to see everybody here. I'm Dr. Michael Clark of the Johns Hopkins University School of Medicine and the American Society of Pain Educators. Before we get started, we'd all like for you to see and hear what makes Pain Week so different from every other pain meeting in this country.
When a patient comes into a provider interaction, they have certain biases and expectations. When these different goals don't get communicated well, patients will often leave the encounter with misinformation or lack of information about how to take their medications properly.
So when people are considering using urine drug testing, it shouldn't be to catch people, but rather as a way of opening up a dialogue and a discussion.
All opioids are not created equally. They can bind differently to receptors, they can have different adverse effects in patients, and it's quite a process in choosing what's the best opioid for any one given patient. We consider variables about the patient, and we consider variables about these medications amongst the class.
Pain is not pain until information gets to the brain. So the really peripheral and central sensitization refer to mechanisms outside of the brain that may lead to enhanced pain being experienced by the brain.
In the United States right now, we really have two enormous public health problems. We have a tremendous problem of chronic pain. And while it's no longer as sexy to talk about it as it used to be, we're an aging society, 50 to 70 million people have chronic pain. Those numbers are only going to increase as time goes on, as our society ages.
Once you have these uric acid crystals in the joint, your body looks at it as if it doesn't belong there, a foreigner, consider it similar to a bacteria, and your body then attacks the uric acid crystal. The trouble with it is these crystals cannot be digested.
Taking control of the prescribing is a long process, and it involves a commitment to what I would consider several months of really looking at where the practitioner stands, understanding the federal platform from a legal regulatory perspective.
In the assessment period, it is critical to understand the patient's experience, and so therefore you want to interview them and ask about the type of pain, its location, intensity, duration, and a variety of factors that might influence it, either making it worse or better.
Earlier in my career, I made the mistake of doing a lot of treatments, which meant the patients had to come back every week for another treatment, and they got temporary relief. And then I realized that it was better to empower them and teach them what they could do for themselves in their own homes to manage the pain and prevent it from becoming too bad.
That's quite an accomplishment. That's an artistic video like none you'll see. And so I'd like to thank the people that put all of that together. We have a number of people to thank here tonight. But in particular, 2011 is a real milestone for Pain Week. This is our 5th year that we've been holding this conference, and it's now become the largest national conference on pain. This year we'll have over 1,500 people attending the conference. And the message really is, how do we bring relief to those people whose lives are oftentimes defined by chronic pain? And so throughout this week, you're going to have the opportunity to take this knowledge back to your own practices. So you've heard that tired phrase, what stays in Las Vegas, or what happens in Las Vegas stays in Las Vegas. This is not one of those things. You don't have to go home and have your wife look at the credit card bill and say, what's a Jigglypuff? And why did it cost $400? You don't have to have your boss say, I don't care what you talked about, that is not a reimbursable business expense. And you also don't have to listen to your 8-year-old walk up and say, "Mommy, what's this?" So please take this information back. Please give it to your patients. Please give it to your colleagues. And we hope to see all of those people, as well as yourselves, next year. I want to just touch on a number of themes that are part of this past year in the world of pain. You've all heard about the report from the Institute of Medicine. The incidence and toll of chronic pain is a staggering one. It's estimated that now 116 million American lives are affected by chronic pain in some way. It's more than the total of heart disease, cancer, and diabetes combined. Pain also costs us over $635 billion a year in medical treatment and lost productivity. And these are some of the realities that motivate us to hold this conference and also to continue to provide the best information we can to all of us taking care of patients. The overarching need really is for education in recognizing pain, making the diagnoses, and then treating them, trying to prevent them and move our treatment up to earlier stages of the pain process. To think about integrated therapies and patient involvement, and perhaps most significantly in understanding pain as a disease rather than just a symptom. So in the words of the report from the Institute of Medicine, in quotes, improving education is especially important for primary care providers, given their key role in pain management. In addition, all care providers should keep their knowledge current by engaging in continuing education programs, and licensure, certification, and recertification examinations should include assessments of providers' pain education, end quotes. Pain Week takes this assessment very seriously and is providing over 100 hours of continuing education to meet this educational need. So for 2011, we're presenting several special interest sessions, master classes, 20 different course concentrations, including rheumatology, neurology, pharmacology, pain, and addiction, just to name a few. We have new offerings this year in emergency medicine and in sex and gender differences in pain management, and those will join our signature tracks to provide integrated multidisciplinary approaches to pain medicine and pain management. Also this year, a new feature is a full-day program presented by Tufts University School of Medicine entitled Pain Education in the Real World, Opportunities and Challenges from Tufts' First Decade. It's an exploration of how pain education can be shaped to enhance its impact in the community. We have over 100 scientific posters and the authors here to speak with you about their work. We have roughly 60 exhibitors and several satellite symposia about product, diseases, medical information programs that will surely capture your interest and your attention. In some, we've really tried to leave no stone unturned during this special Pain Week 2011. Pain management continues to dominate the headlines. States like Ohio and Washington are now responding to the conundrum of opioids, preserving access while trying to combat and obliterate abuse. There are new requirements for patient evaluation, monitoring, and documentation, and specifications for minimal levels of CME and pain management for practitioners. The FDA and other federal authorities are moving similarly to introduce risk evaluation and mitigation strategies, or REMS, and other educational requirements for prescribers, for pharmacists, and patients on various classes of medications. So our curriculum this week will address these areas with specialized tracks in pharmacology, pain and chemical dependency, medical legal aspects of pain management. We'll be providing all of our delegates with comprehensive, current, and fully certified education in these critical topic areas. Of particular note this year is the timely and relevant special interest session entitled Preventing Injury and Death from Opioids, Are Dosage Ceilings in Washington State's Prescribing Policy the Answer? Pain Week is about collaboration and continuing education, and to that end we want to welcome 4 new participating organizations to the Pain Week fold. They are, number 1, the Foundation for Ethics in Pain Care, number 2, the National Fibromyalgia and Chronic Pain Association, number 3, the Power of Pain, And finally, the U.S. Pain Foundation. They bring the total to about 20 professional and patient advocacy groups that support our mission. The Global Education Group is our accredited provider for Pain Week, and we would like to thank Stephen Lewis, Brandy Lewis, Allison Kickel, and Amanda Glazer for doing a superb job on managing all the content development for this conference. Conferences like Pain Week cannot be produced without the support of the health sciences industry. No matter what anybody says, they are our partners, and we should be grateful for the work that they've done and the products they've produced and the ways in which they have improved the lives of all of our patients as well as us as practitioners. So we'd like to thank our commercial sponsors, especially our gold sponsors, Cephalon and Neurogesics. We would also like to acknowledge our numerous media partners who have provided an enormous amount of support and visibility for this conference. Before we present the awards and the keynote address, I'd like to introduce a very special guest of Pain Week 2011. Since its inception in 1985, Myra Christopher has been president and CEO of the Center for Practical Bioethics. She also serves on the board of the American Association of Critical Care Nurses Certification, is a member of the editorial board of the American Journal of Bioethics, and serves on the advisory boards for the Federation of State Medical Boards. Throughout her career, she strived to improve care for seriously ill people and their family members. Myra has now expanded the focus of her work, making her a leading advocate for the treatment and management of chronic pain. Since 2010, she has served as a member of the Pain Study Committee at the Institutes of Medicine, focusing on the lack of treatment available for individuals experiencing chronic symptoms of pain. She is a member of the distinguished panel that published the landmark report, Relieving Pain in America, a blueprint for transformation in prevention, care, education, and research. Please join me in welcoming Myra Christopher.
Thank you, Michael, and good evening. I am Myra Christopher. We don't have sound. Okay, we're waiting till we get the sound on. Okay, closer to my mouth. Thank you. Thank you, Michael. I am Myra Christopher, and I am glad to tell you that I am not seeking the nomination of the Republican Party for the President of the United States. I think most people in this country seem to be doing that tonight. I am, however, very happy to tell you that I have had the privilege of serving on the IOM committee that Michael referred to, where we looked at pain from the perspective of education, research, and care. At the end of June, we released our report called Relieving Pain in America, a blueprint for prevention, education, care, and research. If you have not seen the report, I encourage you to go online, just iom.org, and at least download the 4-page policy brief. I think that you will be pleased that you did. This report is unquestionably the most comprehensive report done on pain in the United States that has ever been produced. And I would argue that it is about time that it has been done. I feel confident that the findings were not surprising to any one of you who has reviewed the report. However, they really were stunning to many people in America. Unquestionably, our findings are dramatic and they are unequivocal. The basic facts are staggering. As Michael said, more than 100 million adults are burdened by pain in the United States. And frankly, although a number of people have questioned the number and gasped at the number, I believe it is an underestimate. It does not include children, it does not include members of the military, nor does it include those who are institutionalized. The problem will clearly only increase as my generation, the baby boomers, age, and as we see more and more problems associated with obesity. The cost of chronic pain with regard to the cost of medical care and loss of productivity are enormous. but I do not believe they compare to the cost in terms of human suffering that people experience. Millions of people receive inadequate pain care for conditions that could be managed. My fellow colleagues and I concluded that pain is a huge public health crisis. I would argue it is the #1 public health issue facing our country. I would also, as a bioethicist, make a strong statement that I think the current condition is morally unconscionable. There is a moral imperative to change the situation. I believe it is a fundamental duty of every healthcare professional to alleviate pain and suffering when and where you can, if you choose to call yourself a professional. I also think it is significant, although it has certainly been hotly debated, that chronic pain may be a disease in and of itself. The bottom line is the solution to this problem will require a cultural transformation, particularly for those who struggle with chronic pain. We must change the way we perceive pain, the way we assess pain, and the way we treat chronic pain. The recommendations that are set forth in the report really focus on 4 areas: public health, clinical models, education of both health professionals and the public, and on research. In all, we made 16 recommendations, and we categorized them as sort of the immediate and the near term, but enduring. I'll mention just a few of those recommendations. We call for HHS to develop a comprehensive national plan and to have it done by the end of 2012. We ask that we shift our approach, or we recommend that we shift the approach from a biomedical model that has clearly failed to a biopsychosocial or integrative pain care model. We must address the barriers that prevent us from making these changes, whether they're legal, financial, regulatory, or cultural. And obviously, education, professional education, is a real key in this whole transformation process. But I also think that education has to be shared with the American public as well, and we need to engage them in this. I have said to a number of people that in Kansas City, where I live, the Kansas City Star gave the report the headline that day, the day it came out, above the centerfold. And the headline simply read, "It hurts." It was stunning to me that for 3 weeks, I really did nothing but accept phone calls from people who were desperately seeking help. Healthcare professionals, pharmacists, lay people, people of all kinds were trying to find help for the problems that they struggle to live with every day. We also recommended strongly that an existing institute at NIH be named the lead institute on pain. I remember clearly Sean Mackey, who is one of the presenters at Pain Week, saying that if it belongs to no one, it will never change. So we certainly hope that that will happen. And we also were pretty outspoken about the NIH Pain Consortium and that it needs to take a more active role. Now, in conclusion, I do not think, and let me just make one more comment because I failed to mention our recommendation about research. We absolutely have to have better research, more research. But we can't wait for more information. Actually, we have enough information right now to make it dramatically different for people in our country. I think we must act now. We all know that IOM reports can be tremendously powerful. We can point to certain reports that have really been springboards for major change in healthcare. But we know that some of them sit on shelves and collect dust. I think we have a window of opportunity right now to use this report to become really the reason for action. I am grateful to each one of you who has chosen to be here and to participate in Pain Week. You are the ones who can give life to this IOM report. You can relieve pain in America. You are the ones who can improve the lives of the 116 million people that we pointed to. You are the ones who can lead this transformation. As I thought about speaking to you, I thought about the old hymn, "Let It Begin With Me." Let it start here, and let it start tonight. Thank you very much.
Thank you, Myra. All right, and now for the finale. This year, Pain Week is very excited to have Dr. Kevin Poe deliver the keynote address, Medicine in the Age of Social Media. Dr. Poe is a nationally recognized opinion leader in the use of social media in healthcare by both patients and clinicians. As social media's leading physician voice, Dr. Poe blogs at MedPage Today's kevinmd.com. Voted the best medical blog of 2008, kevinmd.com is the web's most influential healthcare social platform, with over 100,000 subscribers on Facebook, Twitter, LinkedIn, and RSS. Forbes.com called kevinmd.com a must-read health blog, and CNN.com named kevinmd.com one of its 5 recommended Twitter health feeds. Dr. Poe received his medical degree and completed residency at Boston University School of Medicine and is a member of the 2010 class of New Hampshire's 40 Under 40, recognizing the state's emerging leaders. He's board certified in internal medicine and practices primary care in Nashua, New Hampshire. He's a member of USA Today's board of contributors, and his opinion pieces appear in both national and local publications, including USA Today, CNN.com, and the New York Times. Please join me in welcoming Dr. Poe.
Thank you very much. Thank you very much. It's an honor to be here and speak to you about medicine in the age of social media. I want to start in the beginning of my social media journey, back in May of 2004. I was talking to my brother-in-law, of all people, and he said, "Kevin, you seem to have a lot to say about medicine. Why don't you start a blog?" And I was thinking to myself, like many of you, I see 20 to 30 patients a day. At that time, I was rounding in the hospital. I don't have time to start a blog. I don't have time for social media. Try it, he said. So I went on blogger.com, which is Google's free blogging service, wrote a few articles, shared a few links, wrote some commentary. I wasn't sure where this was leading. And then a few months later, in the fall of 2004, there was a major news event. Vioxx was recalled. And I don't know about you, those few weeks, my office was flooded with calls. We had a lot of patients on Vioxx. People would call and say, "Dr. Poe, did I do any permanent damage? Is there any other medicine I can take other than Vioxx?" So I wrote a blog post giving my thoughts, giving patients some options they can ask their doctors about. And then a few days later, I walked into a room with a patient, and the first thing that she said to me was, "Thank you, Dr. Poe. I read your blog post this morning, and I was comforted by what you had to say and realized that I have medication options to substitute for Vioxx." And I sat there stunned for 2 reasons. The first, that someone other than my mother was interested in what I had to say. And number 2, that social media had tremendous potential to connect with patients. So whenever you hear the word social media, it can be overwhelming. There seems to be a new social media website that crops up every week. Facebook, Twitter, LinkedIn, YouTube, Flickr, Foursquare, Gowalla, Google+, I can go on. But let me simplify it and simply say this. Social media are websites that facilitate the creation and exchange of user-generated content. And that content can be a video on YouTube, a picture on Flickr. It could be a status update on Facebook or Twitter. So the question is, I'm probably sure a lot of you are thinking, why should I care about social media? I don't have time for this. I have patients to see in the exam room. And my answer to you is simple. That's where your patients are going to be. 8 out of 10 internet users use the web to look for health information. It's the third most popular activity after using a search engine and using email. So they're going online and they want to read other patients' experiences. They want to know what it's like to go through a certain treatment, what it's like to take a certain test. And this isn't information that I can necessarily give in the exam room. I haven't taken many of the medications that I prescribe. I've never had an MRI or a PET scan before. But patients want to know, so they go on social media websites and read other people's experiences. 65% of internet time is spent on a blog or social network. I want you to hear from Scott Johnson. He is a patient with type 1 diabetes, and he explains in his own words what social media means to him.
This is Scott Johnson. I've lived with type 1 diabetes since 1980, and I write about my experiences at diabetesdaily.com. Social media gives me access to a world of people living with type 1 diabetes, just like me. Any hour of the day or night, I can tune into discussions on Twitter or Facebook. I can read thousands of blog posts written by people from all walks of life, all living with type 1 diabetes, and I can find YouTube videos that make me laugh and cry. I can find connections. I can find people who understand exactly what I'm going through. These people and their stories become an emotional lifeline. Suddenly, I don't feel so alone or isolated. In fact, I often feel inspired and empowered by what I've seen.
So people are going online and reading health information. It's influencing their health decisions, and in some cases affects whether they see a doctor or not. And that's all well and good, except for the fact that only a minority of them checks the source of what they read. And we know on the web, there's a lot of information, but also a lot of bad and dangerous information. So information from someone who's, say, pushing an agenda or selling a product can have as much influence as something written by a doctor or public health official, especially if patients aren't checking the source. So I think there's a role for doctors and health professionals to go online. After all, we also use the web and look for health information. But we need to go online and help patients to reputable sources of information. If you look at this chart here, doctors use social media websites at about the same rate as the general population, as evidenced by the gray bars. But when it comes to professional use and using it to connect with patients, we use it far less. So the question becomes, how can we use social media to connect with patients? I want to give 2 reasons. The first is this quick 20-second video clip from Wendy Sue Swanson. She's a pediatrician who blogs in Seattle. And she gives one compelling reason why doctors need to be online.
We have to be where they are. We want patients to get great, reliable, compassionate, evidence-based, thought-out, experienced information. And physicians are some of the best people to provide that. How can we not be there?
Social media is tremendously powerful in giving that dynamic physician context that major news media often lacks when it reports health stories. There's a new study that comes out every day. Drugs are recalled. New drugs are introduced. Guidelines change. Patients want to know what it means for them. Social media is the only platform that can dynamically keep up with the pace of breaking news. I want to give a second reason why doctors need to be online, and that's to dispel myths. I talked earlier that there's a lot of bad and dangerous information, and nowhere is that more prevalent than in the false connection between vaccines and autism. You Google vaccines and autism, and you're going to get information all over the map. articles from people who are pushing an anti-vaccine agenda can rank as high on search engines as legitimate information from doctors or public health agencies. Patients are confused. They did a study, a survey a couple of years ago, and they asked patients, is there a connection between vaccines and autism? 52% of the country said, no, there's no connection. But think about that. That means almost half of the country wasn't sure. Now, why is that? One reason is that those who push the anti-vaccine agenda have utilized the online medium much better than health professionals. You go to sites like the Huffington Post, they get millions of readers, and celebrities write on their site, and they plant that seed of doubt in patients' minds. And patients are confused. Paul Offit, he's an anti-vaccine, he speaks out against the anti-vaccine movement, and he said it's much harder to unscare people than it is to scare them. So we physicians and healthcare professionals have the hard job in the exam room. Jim Carrey and Jenny McCarthy, they have it easy. They could plant that seed, but it's up to us to unscare them in the exam room. And the longer it takes for us to get online, the harder that job is going to be. So how do we use social media to take back the online medium? I'm going to talk about blogs, Twitter, and Facebook. So I've come a long way since that conversation with my brother-in-law back in 2004. My site gets about 4 million page views every year, which means about 10,000 of my stories are read every day. And someone wrote this about my blog and said, a comment stream on one of Kevin's posts provides more insight on the realities of healthcare than any piece of journalism can ever hope to impart. And that's exactly what I try to do. I want to pull that curtain back and let patients see some of the obstacles that physicians face when we practice medicine, whether it's the time pressures, the bureaucracy, the paperwork. Because let's face it, physicians have a relatively weak lobbying power when it comes to healthcare policy. And in order to get anything done, we need to get patients on our side. Because the harder it is for us to practice medicine, the worse care we give to patients. But that transparency also goes both ways. I think it's important for us to hear what patients are saying as well. Because no matter how bad we have it, patients have it worse. They're dealing with a lot of the same issues we are. They're dealing with paperwork. They're dealing with bureaucracy. They're dealing with the increasing cost of healthcare. So some of the comment streams on my blogs where patients give a raw account of what they're dealing with, I've learned from them. I've listened to them. I've changed how I practice. Some patients say, doctors never call me back after I have a test. I have to wait months to see an appointment. I have to wait months to see a doctor for an appointment. But by listening to them, I've changed the way I practice, and it's helped me become a better doctor. So I want to share a couple of stories that were particularly interesting during my blogging journey. The first happened last year. I got a call from John Schumann, who's an internal medicine physician. He said, Kevin, there's an interesting case. My friend, who's a Harvard law professor, is in the hospital with fever of unknown origin. And his medical team is at a dead end and didn't know what was causing it. And the interesting thing was that he was live blogging his hospital stay. And I said, what do you mean he's live blogging his hospital stay? Well, he had a blog, and every time he had a consultant come in or a test result come back, he would put it up on his blog, hopeful that someone would read it and shed some light on what was causing it. He was trying to crowdsource his diagnosis. So it was fascinating. So I wrote that piece on my site, knowing that a lot of doctors would go from my site to his. And not only would he get second or third or fourth opinions, he would get hundreds of physician opinions. And one of the doctors recognized the symptoms from a case study in an obscure South Korean medical journal. Hemangioma of the liver. Why don't they test for that? And that's what this professor had. Fascinating case. It was written up by Lisa Sanders in her New York Times diagnosis column. But this is a stark example of how patients are using social media to empower themselves and giving them a voice in their own care. I want to share a second story. It was from a pediatrician. He blogged under the pseudonym Flea. And unfortunately, he was undergoing a medical malpractice trial. So thinking that he was anonymous, he would write a pretty raw account of what was going on every night he came back from court. It was fascinating reading. But in his raw accounts, sometimes they were a little bit disparaging to both the plaintiff and the plaintiff's attorney. So one day, while Dr. Flea was on the stand, the plaintiff attorney stood up and asked him, "Are you Dr. Flea, and did you write this?" And he was forced to say yes. And that case was settled that afternoon. It made front-page headlines in the Boston Globe. Blogger unmasked, court case upended. So again, 2 lessons from this. Number 1, never live blog your medical malpractice trial while it's going on. And number 2, there is no anonymity on the web. So if you do engage with social media, do so under your real name. It will act as a filter to prevent you from saying things that you're going to regret later. The topic of pain management often comes up. I write blogs on it. I have guest authors who write on it. And in the comments, you get a sense of the frustration patients are feeling when it comes to pain management in our country. You get comments like, it's easier to buy opiates on the street than it is to obtain a chronic pain medication prescription. Or that doctors need to wake up and realize that chronic pain patients are in a no-win situation. And as you've heard earlier today, the Institute of Medicine agrees in their report. 116 million Americans suffer from chronic pain, more than diabetes, heart disease, and cancer combined, at a cost of over $630 billion. Education, or the lack thereof, is a key factor. Not only between doctors and patients, but also between primary care doctors and pain management specialists. I think social media can play a role in helping to bridge that gap. Use social media to spread articles where you can inform patients that there are choices other than opiates to treat pain. And educate me, a primary care doctor. You know, there are only 5 medical schools in the country that have required pain management courses. I would definitely welcome more guidance from pain management specialists, and they can use social media networks to spread that message and improve pain care. So over the last few years, blogging has strengthened, but also Twitter and Facebook have come into the forefront. And whenever I talk about Twitter to doctors and other health professionals, they always say, "Kevin, that all sounds good, but you know, I'm just not quite sure what Twitter is." So I'm going to show a quick 2-minute video so we can get everyone on the same page before we talk about Twitter.
So, what are you doing? It's one of the first questions we often ask friends and family. Even if the answer is just mowing the lawn or cooking dinner, it's interesting to us. It makes us feel connected and a part of each other's lives. Unfortunately, most of our day-to-day lives are hidden from people that care. Of course, we have email and blogs and phones to keep us connected, but you wouldn't send an email to a friend to tell them you're having coffee. Your friend doesn't need to know that. But what about people that want to know about the little things that happen in your life? Real life happens between blog posts and emails, and now there's a way to share. This is Twitter in plain English. Thanks to Twitter, it's possible to share short, bite-sized updates about your life and follow the updates of people that matter to you via the web. Here's how it works. Meet Carla. She's addicted to her mobile phone, reads blogs every day, and has contacts all over the world. She heard about Twitter and was skeptical. After some of her friends couldn't stop talking about it, she gave it a try. She signed up for free and saw that Twitter pages look a little like blogs with very short posts. Each page is personal and has updates from friends. She got started by looking up her friends on Twitter.com. After finding a few, she clicked follow to start seeing their updates on her Twitter page. Within hours, she began to see a different side of people she chose to follow. She didn't know that Steven in Seattle was a baseball fan, or that Julia in London was reading a new investment book. The little messages from Twitter painted a picture of her friends, family, and coworkers that she'd never seen before. It was the real world. Soon, she became a fan of Twitter and posted updates every day. Her friends followed her updates and learned that she recently discovered a passion for Van Halen. They could see Carla's life between blog posts and emails. For Carla, Twitter worked because it was simple. The updates were always short, under 140 characters. Plus, she could post updates and follow her friends using the Twitter website, software on her browser, a mobile phone, or instant messages. By asking members to answer the question, "What are you doing?" Carla found that Twitter brought her closer to people that matter to her, 140 characters at a time. Find out what your friends are doing at twitter.com.
Twitter offers instant engagement. I like to say it's an instant message to the masses. Whereas in blogs, you write an article and you wait for the comments to come in Twitter, you'll know about that instantly. If someone agrees or disagrees with you, you're going to know right away. Twitter also flattens hierarchies. You can engage people on Twitter that normally you couldn't. I want to give you an example of these two concepts at work. I write for the New York Times Room for Debate blog, and when they want a piece from me, they want it the next morning. So one day they got an email from them and said, "Kevin, can you write something on this topic? Name one thing Medicare should stop paying for." So I had plenty of ideas, but as an experiment, I wanted to go on Twitter and see what my followers thought. So I posted this. I wanted to crowdsource a topic. A few minutes later, I got a response from Kenny Lin. He's a family physician, but not just any family physician. At that time, he was on the U.S. Preventative Services Task Force and was a lead author of the prostate cancer screening guidelines. And he said, "Why don't you write about the lack of evidence of PSA screening in men over the age of 75? I thought that was a provocative topic. And the next day, I wrote that piece, got published in the New York Times. So this is an example of how I use Twitter to crowdsource a topic. I engaged someone in a relative position of authority, and it turned out into a piece in a major media platform. Twitter also has a powerful ability to break news. There's a saying, nothing breaks at the speed of Twitter. And I want to take a moment or two and step outside the world of medicine and see how this works. Earlier this year, the Middle East uprisings. Communications were shut down. How did the anti-government forces communicate, let alone organize? It was on social networks like Twitter and Facebook. And when the government in Egypt shut down the internet, they used tools like speak to tweet, which is using the telephone and transcribing their conversation into Twitter so they can organize and disseminate their message to the rest of the world. How about the tsunami and earthquake in Japan? Again, communications were down, but strangely enough, the internet was still up. So people would get on Twitter and give a first-person account of what was going on, and in some cases would guide rescue forces to the areas of most need. In fact, some would say that Twitter was a vital lifeline during those desperate times. Hospitals are starting to take advantage of that real-time, first-person nature of Twitter. I happen to practice in a part of the country where there are a lot of blizzards, so sometimes hospital services shut down. So some have gotten on Twitter and given updates as to what's open and closed as it happens. Some hospitals go to Twitter to post emergency room wait times so people can get a real-time snapshot of how crowded the emergency room is. During the H1N1 pandemic in 2009, the CDC has a large Twitter following, 1.2 million people. So as the news was changing, the CDC would put updates on their Twitter page. And then it would drive traffic to the cdc.gov website, almost 250,000 visits. I think one of the more understated uses of Twitter is simply to listen. And you don't even need an account for this. You can just go onto Twitter and search any topic, follow a few thought leaders, and just listen to what they have to say. It's one of the most effective ways to stay updated. I have groups of people that I follow, social media experts, health policy experts. I'm a big football fan, so I follow people who write about the New England Patriots. By following them, listening to what they have to say, and more importantly, clicking through to some of the links that they share, it's an ideal, effective way to curate the web. Because there's a lot of information out there. We need someone to filter it. Twitter is one way we can do that. So as popular as Twitter is, it really pales in comparison to Facebook. Mark Zuckerberg got up on stage a couple of weeks ago, and he said that there were 750 million users on Facebook. If Facebook itself was a country, it would be the world's third largest. And people spend a lot of time on Facebook, about 14 minutes per day. And you may think that may not be a lot, but that's more than Google, YouTube, Wikipedia, and Amazon.com combined. I want you to take a moment, close your eyes, and think, who is the typical Facebook user? A lot of you are probably having images like this. Your kids, teens, preteens, sometimes in the middle of the night. Who knows what they're doing on Facebook? And that may be true. But if you focus on them, you're ignoring one important demographic who also uses Facebook. Let's meet them. Your Medicare patients are also on Facebook. Don't ignore them. They're adopting social networks at the same rate as your younger brethren. In fact, do you know what the fastest growing demographic in Facebook is? It's women between the ages of 55 and 65 years old. And Facebook is the number 3 most visited site in patients 65 years and older. There are some people who never leave the Facebook ecosystem. In fact, some think Facebook is the internet. So it's important for health professionals to get online because people are reading news on Facebook, they're getting health information on Facebook. And it's a golden opportunity for us to get on them and connect with them. Of course, Facebook has led various media outlets to ask some questions about it. The New York Times even asked, should doctors be on Facebook? And in the UK, people would go to physician profiles, see whether they're married or not, and then ask them out on dates. They would be called Facebook flirts. And the question always boils down to this. Should doctors friend patients on Facebook? And my answer is no. There's a lot of personal information on a typical Facebook profile, pictures of your kids, what you did after hours, what you did on vacation. This isn't necessarily information that you want to share with your patients. I think it blurs that line between the personal and the professional. Instead, I suggest what's called dual citizenship. Have 2 profiles. You could have a Facebook profile that's closed to the public but only open to your close friends and family. And then you could have a separate Facebook page that's open to the public. And that could be your professional face where you could talk about your practice, share and educate patients. It could be tremendously valuable in reaching out to people who are on Facebook. So the intersection between healthcare and social media is still in its infancy. So some doctors have asked me, Kevin, are there any rules that I should follow? And last year, the American Medical Association came out with some social media guidelines. I want to touch upon a few. And the first is patient privacy. HIPAA, which is the federal patient privacy law, should be the minimum standard, and all health professionals should aim above that. Be careful before you hit enter. Be careful if you talk about cases, because it's very easy on a social network to inadvertently reveal patient information. There was a doctor earlier this year from Rhode Island. She had an anonymous account on Facebook, and she talked about a unique case that she had seen. But that case was so unique that someone who read her Facebook update recognized the patient as well as a hospital she worked at. She violated HIPAA. She lost her hospital privileges and was sanctioned by the Rhode Island State Board. Don't get fired from using social media. It can happen. It's not worth it. Stay professional and realize that how you act online should be no different from how you act when you're in the room with a patient. I have what's called an elevator test, and it's simply this. If you say aloud what you type into a social media network in a crowded hospital elevator, would that be okay? And if the answer is no, or if the answer you're not sure, don't hit enter. Wait until the next day and see how you feel about it. Because you'll be amazed at how fast things can spread on a social network and how easily you can get into trouble. So a few take-home messages. The first is this. What you write on the web is written in ink. Whenever you hit the enter key on a Facebook status update or on a Twitter update or on a blog post, it gets indexed by a search engine like Google. And once it gets indexed, it could always be looked up in the archives, even after you delete it. So think before you hit enter, because once you do, it's tattooed on the web. But you can use that permanency to your advantage and build what's called your digital footprint. Now, what's a digital footprint? It's this. It's all the online information that's associated with your name. It could be your blog, it could be a Facebook page, or something on LinkedIn. And that's important because patients are not only looking for diagnosis, treatments, and medications online, they're looking for you online. They're looking for doctors and hospitals online as well. Gone are the days where people are going to be looking you up on the yellow pages. They're going to start using a page like this and typing in your name. So if they type in your name, it's to your benefit that you be in control of what comes up. For me, my blog comes up, my About page comes up, I have a page on Twitter and LinkedIn. They get ranked high on Google search engines. But what if I didn't have a social media presence? What then? Probably something from a third-party physician review site. Every one of you should Google your names once a week. The problem with third-party review sites is that not only are they inaccurate, you don't control the information that comes up. So when patients search for you, you're powerless. So when I say getting involved in social media, obviously everyone's busy. You don't have to use social media to the extent I do. Do what you're comfortable with. Tiptoe in. I recommend starting a page on LinkedIn or a Google profile where you could just talk a little bit about your practice. You could put in a few lines on your resume. Just that simple act will put you far ahead of the curve compared to other healthcare professionals, because that piece of information will get ranked highly when someone Googles your name. And when you get comfortable with that, then maybe you could start engaging, going on Twitter, sharing a few links, and then start a blog, write a few articles. But only start with what you're comfortable with first, and then gradually build up. And once you do start contributing to social networks, you're going to be amazed at how fast you can spread the news. I talked about dispelling myths earlier. And one of the best ways to dispel myths is to flood the web with reputable health information. The American Heart Association, they wanted to push chest-only CPR. Did they put out a television spot? Did they go on the radio? No, they went and hired Ken Jeong, the family physician, comedian actor, and posted this video on YouTube. 400,000 views in a span of a few weeks. Social media is tremendously powerful in spreading the news and spreading your message. So it's inevitable with patients going online. Some are going to come to your office with printouts from the internet. And doctors and healthcare professionals, we're faced with two choices when this happens. Number one, we can roll our eyes, tell patients not to go online, as I know some doctors do. Or number two, we can embrace it and realize that no matter what we say, what we do, or what we think, it's going to happen anyway. That's why connecting with patients online is a healthcare imperative for the 21st century. The longer it takes for us to realize that, the bigger the disconnect we're going to have with patients in the exam room, and that's going to make our jobs harder. Social media gives us powerful tools, not only to connect online, but also to preserve and strengthen our relationships with patients. Thank you.